We'll be talking about bias and error mitigation and correction, as the title would suggest. Couple of things. First off, mitigation is pre-diagnosis and correction is post-diagnosis. Most of what we've been looking at is post-diagnosis because mitigation of bias in particular, and error necessarily, but bias in this context, is done post-diagnosis. As an introduction to the topic, let's have a look at bias and error in general. Essentially, bias is a tendency towards a particular conclusion or judgment. We're talking about clinical reasoning now. So you prefer a particular diagnosis or a particular treatment, and there's a tendency towards that, favour it. It's about methodology or the reasons behind methodology, but it's cognitive. Let's get some definitions out of the way. As I say, mostly we're going to be talking about unconscious bias. As I say, there's not much anybody can do about prejudice, which is what uncorrected and known bias is. But bias is basically a deviation that occurs systematically from individuals. In this case, we're talking about clinical reasoning now. And it's occurring because of influences that you have. Bias is basically a leaning towards or a tendency towards, and bias isn't always bad. You use bias all the time. For example, a heuristic is a shortcut, and this is based on bias. Usually it's a bias of your experiences. For example, tennis elbow. So a patient comes with lateral pain. The heuristic is, I see these all the time. There seems to be as many types of bias as there are psychologists. A lot of these biases are the same bias but with different names, and sometimes it's difficult to wade yourself through it. On the other hand, you have a bias. We'll take availability bias. You have a named bias, and then there's subtypes of that bias. In this case, availability bias is where you simply have a tendency towards the most available. Okay, search satisfaction or premature closure, or premature satisfaction is where you accept the diagnosis without fully exploring other possibilities. This is very common. Let's look at the case of the tennis elbow again. Lateral elbow pain, you've made the hypothesis of it being a common extensive tendinopathy. This is your availability bias, which can work well, but in this case, it doesn't. Okay, so we're looking at the non-clinical aspects of bias mitigation. This is not during the examination process at all, or the treatment process. So this is a list of things to do and don't, and as always, it's a bit abstract really, but nonetheless, you need to take note of this. The first one is be self-critical. You're not as good as you think you are. Your results are not as good as you think they are. Okay, we're going to look at bias mitigation at the point of service during the diagnostic and treatment session. And mitigation occurs before the diagnosis, and correction occurs after the diagnosis is made. Most of this will be about correction of the bias error. So for mitigation, one of the best ways you can do this is so bias correction occurs after the diagnosis has been made. Don't do it before. In fact, you can't do it before. You've got to do it afterwards. So what we basically have coming into this is a provisional diagnosis. So you generated H1, you've proven H1, you now have a provisional diagnosis, and it's provisional on for premature closure. Again, exclusionary differential diagnosis. The reason I'm using exclusionary differential diagnosis all the time is because this is a routine part of the exam, or at least it should be. Eventually it'll become unconscious. You'll just do it in your head, or subconscious actually, because you can actually remember it when prodded. But you will do it in your head and it'll be over and done with very, very quickly. So for the moment, do it formally until you know better. Do it formally and use exclusionary at the end of the diagnostic process. Bias-based errors are essentially dealt with by dealing with the bias. So if you can mitigate or correct the bias, then any errors coming from it should disappear, or at least get significantly lower. So basically, differential diagnosis in one form or another, look for patients' concordance, agreement with you on what their answers were, on how you interpret the test by looking at your conclusion. As far as random errors concerned, or non-bias based errors, I think these are probably the commonest ones. First off, you've got knowledge gaps. You just don't have that information. It's either never been taught to you or you've forgotten it. You need to learn from every case. So as you come across a knowledge gap, or maybe it's just you're a bit iffy on the knowledge, learn it. And do it as you go. Don't try and don't study this. Specifically look up areas where. Let's put some of this to practice in, shall we? Basically what you get from the patient is presenting signs and symptoms and a profile of the patient. You don't need all this. You don't need all of their presenting signs and symptoms. You want the stuff that is immediately relevant to making the diagnosis. Now, this may or may not include the profile. Generally speaking, you don't actually need that neither. And if we're going to do essential illness scripts in this, okay, I promised a bit more detail. You need pain location. In fact, that's all you need to help generate the first hypothesis. You don't need any other information from the patient. So we generate H1. Now we can do it through a single hypothesis, which is basically availability. Generally this is what it is: lateral pain, common sense tendinopathy. On the other hand, what you may want to do is generate H1 if there are serious consequences to being wrong. So for a motor vehicle accident, your first hypothesis might be there's a. So to summarize this presentation, this is sort of an algorithm form, but I don't really want you to follow this slavishly. I want you to understand it. You can then make your own structures up, but understand the process. So first thing to do is generate a hypothesis. You do this anyway, you just don't formalize the idea, and I want you to start doing that. So generate a hypothesis, and as I said, this is most usually done with exclusionary differential diagnosis as far as bias is concerned.